Good day to you all. My name is Cara Lewis, and I'm here to talk to you about pragmatic measurement of implementation outcomes, and specifically how to operationalize outcomes that are important to health systems and practice partners. So my talk will begin with a roadmap to operationalizing a learning health system, including key inputs, outputs, and outcomes based on recent work led by a team here at Kaiser Permanente Washington Health Research Institute. I will then link the learning health system with implementation science explicitly, showcasing two different scenarios about how they best come together for maximal bidirectional impact. And then I will dive deeper into implementation outcomes with an emphasis on how to select outcomes that matter to stakeholders and design pragmatic measures. I will try to share ways to balance rigor and burden in the context of learning health system impact evaluations. So I will move on to make sure we're on the same page as we get started. There are indeed many definitions of learning health systems. I will offer Rockville's here, who suggests that a learning health system is a system in which internal data and experience are systematically integrated with external evidence, and that knowledge is seamlessly put into practice. As our Kaiser Permanente Washington Learning Health System became a formalized, funded, and coherent entity, we sought clarity about how others operationalize their learning health system consistent with this definition. And indeed, many organizations have explored LHS concepts and values. Most articles, though, are theoretical or commentaries or implementations in specific settings. And when we conducted this search, we found that very few learning health system programs actually evaluated their impact of their LHS on their outcomes of interest. So we undertook a study inspired by this observation that knowledge of developing, operationalizing, and evaluating the impact of a learning health system is actually quite scarce. We also really wanted to be accountable to measurable impacts of our learning health system efforts and be transparent about how we accomplish these things if we were to be successful. Our objective for this particular study was to develop a roadmap that identifies and defines core components of a learning health system and demonstrates how they relate to one another when operationalized in practice so that other organizations could improve and evaluate their own systems as well. And this paper that I keep referencing at the bottom of the slides was written by and led by Claire Allen from KP Washington for an audience of organizations who actually want to start, improve, or evaluate their own learning health system efforts. We formed this interdisciplinary group of learning health system researchers, and we used a narrative review approach, which is appropriate when the question of interest is too broad or the body of evidence too sparse for a systematic review. From this work, we identified 17 different models of LHSs. We decided ultimately to use the framework from Geisinger as a starting point. We compared it with others to identify omissions, the need to parse apart or expand definitions. We used other studies from this review to identify additional constructs to layer onto the Geisinger framework, and we clearly defined each construct in measurable terms. It was very important for us to get to measurable outcomes. And then we organized these constructs to show the relationship between them and categorize them ultimately as inputs, outputs, and outcomes. So we landed on 24 distinct constructs across these three categories that I'll show you next. And this was our best effort to harmonize across these 17 different models that we identified. And it became very important to us, if you know my particular work, I'm a bit of a measurement nerd. It was important to us to offer some guidance in terms of how to measure these constructs. So what you see here are the 6 inputs or fundamentals, the 9 outputs or key activities, and the 9 outcomes of greatest interest. And I will dive into each in turn. So in terms of inputs, there are 6 fundamentals that are part of a high functioning learning health system. I will largely gloss these as they are pretty self-evident from my perspective. I will say, though, that I think the majority of learning health system programs have the people and partnerships in place, as well as this or some version of a health information infrastructure, but it's not clear to me the extent to which learning health systems predominantly have strategic alignment, sufficient funding, an improvement infrastructure, or coordinated ethical oversight. In terms of outputs, there are 9 that might be key activities of high-functioning learning health systems. But this is where I personally suspect most of the variation occurs from learning health system to learning health system. I really think of these as core capabilities, and to some extent, they're going to be defined by the expertise of the team members who are present. So, for example, are there evidence synthesis experts available to wrap their arms around the literature in an efficient yet rigorous way? Are there nimble biostatisticians who speak delivery system operations language and can identify opportunities? Are there community engagement experts? Are there implementation science experts, communication experts? In our KP Washington Learning Health System, we have these types of experts. And how I see this working in each of these spaces is that the researchers who have this expertise, they fancy themselves methodologists. So they find joy in adapting rigorous methods that they might use in trials, for example, and they bring them into this pragmatic application space. So I thought it might be useful to offer an example or two. I'd like to highlight the work of Nora Henriksen, who leads systematic reviews for AHRQ's Evidence-Based Practice Consortium that informs the U.S. Preventative Services Task Force guidelines. She takes her methods into forms that can satisfy rapid evidence needs of our delivery system. In fact, hopefully her workshop will be accepted for the Academy Health D&I conference this December, so that you can see exactly what she and her team have developed in terms of rapid evidence need methods. I see biostatisticians like Yates Coley scrutinizing electronic health record race and ethnicity data, who surface the potential for actually exacerbating disparities based on this data that lives in our EHR, and see them generating and testing and refining methodological approaches to rectify these challenging data issues. So these are just 2 examples where the best research methods are brought to face new challenges within real contextual and time constraints and be responsive with innovations that respect rigor and pragmatism. All right. Moving on to outcomes. When you're thinking about outcomes that might be important to health systems, I think this list is a really great place to start. These outcomes span processes, primary and secondary impact, and programmatic and project-specific types of outcomes. As you look through this list of LHS outcomes, you can see really how aligned they are actually with implementation outcomes. So here we see adoption, de-implementation, reach, acceptability, appropriateness, and cost. These are key implementation outcomes that our field cares deeply about, and they're central to learning health system efforts. So before I dig, though, deeper into implementation outcomes, I thought it was worth highlighting that standing up a learning health system with these inputs and outputs may be one structure or system or way within which to support and engage in implementation science. So on this slide, you see how learning health systems might spur implementation research with inputs of the health information technology infrastructure, people and partnerships, and ethical oversight. I really appreciate the work of Noah Ivers in Canada, who writes with these international colleagues about the use of audit and feedback as a quality strategy. Indeed, audit and feedback is common, it's scalable, it's adaptable, and it has hundreds of trials demonstrating its worthy impact. Learning health system programs might use audit and feedback as a core implementation strategy to stand up new initiatives, drive fidelity, and strive for health equity. But to optimize audit and feedback, which can take many forms, we need to understand how to operationalize it in diverse contexts for unique practices to achieve desired outcomes. So how do we power for this and scientifically learn how to operationalize audit and feedback? Well, Jeremy Grimshaw, along with Noah Ivers and colleagues, have launched an audit and feedback global meta lab, where they can very efficiently launch trials of audit and feedback in these learning health system contexts around the world to test variation of audit and feedback in diverse settings. They're pioneering the idea of meta labs, helping to improve the implementation of evidence-based practices with each trial that they do, while they're simultaneously advancing the literature in ways that never before has been possible. So they're opening this door for similar work with other discrete implementation strategies to be testing in these meta labs by leveraging the LHS system. So that's one scenario of how LHS and implementation science can come together. Another scenario is to see learning health systems actually leverage implementation research. And this might really demand inputs like improvement infrastructure, prioritization, and funding. But I think, so in terms of taking advantage of leveraging implementation research, methods, principles, best practice, and evidence, the VA provides us with a really nice example of this. So their query roadmap showcases how they use implementation science to think about integrating new practices across phases, and I'll show you in a table that you can hopefully see, bringing in discrete strategies of greatest relevance in each phase, utilizing measures from the field to inform movement across these phases. And just for example, in the pre-implementation phase, they emphasize the critical import of clarifying first the evidence-based practice core elements or functions to make clear which aspects are adaptable or to free up different forms that an evidence-based practice could take. They then move into careful selection of implementation strategies in that middle column and explicitly have a sustainment phase as for how they conduct their work to ensure the institutionalization of an evidence-based practice and make good on their investment. So this is a second scenario of how implementation research and learning health systems can come together. Well, how do health systems like the VA operationalize implementation outcomes? There are numerous frameworks to guide us. Perhaps one of the first was REAIM, developed by Russ Glasgow and colleagues in 1999. What's nice about REAIM from my perspective is the mix of effectiveness and implementation related outcomes, which offers relevance to hybrid trials, effectiveness implementation hybrid trials that I hope to see being more and more common over time. Then we have Proctor et al.'s seminal implementation outcomes frameworks, as I've referred to it, which very intentionally differentiates the implementation outcomes from the service outcomes, from the patient outcomes, almost in this linear sort of domino relationship or effect where improving implementation outcomes ought to improve service outcomes and then patient outcomes. What's exciting to me is that, led by Rebecca Legnick-Hall, working with Enola Proctor and colleagues, they are spearheading a 10-year systematic review right now to offer updates to this framework, and it's coming your way soon. And then as a third example of an implementation outcomes framework, we recently saw the CFR Outcomes Addendum published, which I've grabbed a screenshot for you and put on this slide. I'm still wrapping my mind around their distinction between antecedent assessments, anticipated versus actual outcomes, and innovation outcomes, but I really do appreciate the centering of equitable population impact here on the right. And as you can see, as I suggest in the slide title, there is incredible synergy across these frameworks. So to some extent, you can't go wrong when you're trying to make a selection. But really, how do you select a framework? How do you prioritize implementation outcomes? Well, here are some principles that might guide you. Engage stakeholders early. Whose voice matters in selecting outcomes? Whose voice is missing at the table when those conversations are happening? How will I know if that voice is missing? And what does that mean for the interpretation and potential implications of the findings that surface from the initiative or from the research? You want to identify outcomes that matter to stakeholders. Did you create an environment where they can raise their voice and share what they really care about? Did you use language that resonates? So we often say in a first meeting with a partner, a practice partner, what's a win for you through this partnership? What's a win for you through this implementation? Other questions you might ask yourself are about differences across stakeholder groups when they are surfacing and prioritizing implementation outcomes. How do you reconcile those differences when they emerge? And once our outcomes are articulated by stakeholders, my suggestion is to then go back and look at the frameworks and see how they align and see if they can help inform how you would measure the outcomes that your stakeholders prioritize. I want to underscore the importance of critically scrutinizing all outcomes for inequities. So this really does demand additional attention. Here you see a table that I put together from Rachel Shelton and colleagues' paper of addressing the dynamic context and promoting health equity over time, bringing that lens to ReAIM. In their article, they posed questions. These, I think, are their questions for each outcome that are motivated by health equity considerations. They're super practical questions that can bring to your work, that you can bring to your work to ensure equitable population impact is achieved. Let's just look at one example. Reach in and of itself, people sometimes conceptualize as an equity-related outcome. But within that, you need to ask yourself things like, are all populations equitably reached by the evidence-based intervention? Who is not being reached by the intervention and why? And you might think carefully about social dimensions, social positions, social determinants of health, environmental and contextual circumstances when you're thinking about this. And then it becomes about the how. How can we better reach those who are not receiving the intervention and ensure that we're reaching those who experience inequities related to these social dimensions? And they have these practical questions across each of the outcomes that can guide your thinking. So this is an odd looking figure. It's a graphical depiction, a template of what we call causal pathway diagrams. I'm going to unpack this for you, but I want to start by saying too often I have seen implementation initiatives or trials go 5 years, 7 years before they yield null results or suboptimal impact on the implementation outcomes that got them started to begin with. My perception is that we need to do better for our practice partners, for our practice community. We need to fail more quickly. We need to start looking for early signals of effectiveness. Our team thinks of, perhaps this is confusing, but our team thinks of implementation outcomes actually as distal. And I suggest that it might be confusing because in the slides I just showed you from the Proctor et al. Implementation outcomes framework, implementation outcomes were actually more proximal than service and patient outcomes. But if you think about implementation outcomes like fidelity, like sustainment, as that which you're striving for, there has to be intermediate and proximal outcomes that are observable early indicators that an implementation strategy is having the intended effect. And these are the types of outcomes that actually might be more pragmatic in terms of their measurement. And they might be really aligned with what your stakeholders care about. And so using these causal pathway diagrams, we can start to articulate these earlier outcomes, evidence of a signal that we're on the right path to success. Compared to other evaluation frameworks that I showed you, these causal pathway diagrams, they demand much more nuanced thinking, process-oriented thinking, and a causal lens, hence their name. The other benefit, though, because of this, using CPDs, causal pathway diagrams, as a graphical tool, even a communication tool with your practice partners, it requires that we check our assumptions. So putting a CPD together for something like audit and feedback actually demands that we make a convincing argument that implementation strategy X is likely to activate mechanism Y to yield outcome Z. Let's consider a concrete example. So let's say an organization wants to improve early detection of depression through the evidence-based practice of routine screening. Their distal implementation outcome is depression screening rates, or REACH. They have the implementation strategy of electronic health record decision support prompts for depression screening as a promising strategy to achieve that distal implementation outcome. And in the exercise of filling in the boxes, circles, and the stop sign, they might be able to check their assumptions that indeed that strategy holds promise in achieving that ultimate distal outcome, but it also might surface proximal and intermediate outcomes that they can see as early signals that the strategy is overcoming the barrier or determinant of divided attention to ultimately get to their distal outcome of interest. So, pragmatic measurement. I've referenced this a couple of times and think it's even in the title of the slide of the talk. Let's get into that a little bit more now that I've articulated discrete implementation outcomes and shown you some frameworks that can help in your selection. But first, I want to share why I think so much about measurement. I really like this quote of something Siegel said in 1964, that science is measurement. Any study you seek to undertake, any question you seek to answer requires that you measure things. It is not always the case that we are measuring perceptions, beliefs, and attitudes, but it is often the case that we're doing that in the context of implementation research. And we use self-report measures to tap into those perceptions, beliefs, and attitudes. Unfortunately, measurement is not necessarily always scientific in terms of having evidence of reliability and validity for how things work. So our team tried to help the field out a little bit. And we, through a series of studies, created what we refer to as papers. I know it's a terrible acronym, but it stands for the Psychometric and Pragmatic Evidence Rating Scale. We borrow from earlier work to put forward dimensions of psychometric and pragmatic properties and scales that allow us to assess the evidence of measures of common implementation constructs and outcomes. And on the psychometric side, there should be no surprise here. These are common psychometric properties when we're looking at classical test theory. I will acknowledge there are newer, more sophisticated approaches to measure development, like item response theory, that can actually offer us more pragmatic and personalized measurement, but I won't be able to speak to you about that today. Staying with classical test theory, we care about things like reliability or consistency of measures, convergent, discriminant, known groups, predictive, concurrent, and structural validity. I won't go into the details of what each of these mean, but the extent to which measures are assessing that which we intend to, responsiveness or their measures' ability to detect change over time, and norms. So those are pretty standard that most of us know about, and what our team proposed to do and actually has completed now is assessed common measures that we could find in the literature for these psychometric properties and put them in a repository for you all to access. But we wondered, and I'll go back for a moment before I distract you with those new boxes, to say that our team thought about measures as tools, that implementation constructs such as leadership or readiness. If organizations themselves could assess these constructs with reliability and validity, perhaps they could use that information to plan more independently about an implementation effort or a learning health system project or initiative. Now, we wondered, if measures were to function as tools for the practice community, what properties ought they have? What should they look like? And we went through this multi-step process with stakeholders to articulate the pragmatic properties or dimensions of measures for implementation. And they shook out into these two types: the subjective type in the middle, which are stakeholder facing. They're in the eye of the beholder. So stakeholders themselves need to tell us, and they said these were the important dimensions: if the measure was acceptable, if it offered relative advantage over existing methods, if it could be completed with ease, was appropriate, fit their organizational activities, and could inform clinical and organizational decision-making. Our team, through systematic reviews, could assess these objective features of measures that the stakeholders also prioritized, which include low cost, use of accessible language, low burden on the assessor, and brevity, and that they were brief. Across all these properties, when we do systematic reviews or engage stakeholders, we use this, this scale here, the 6-point scale, that tells us about the level of evidence for measures, whether it's excellent or there's no evidence at all. So and there is one level indicating that evidence was poor. It's actually the opposite of what was intended. But this really just gives us a sense of, for this relatively new field of implementation science, how advanced is the evidence for measures to do what they're intended to do. And so when it comes to implementation outcomes, you can find a 2020 publication that is open access that resulted from our NIMH funded R01, assessing the quality of measures of implementation outcomes. And so I'll just give you a glimpse at what you can find in that paper, which is all of the Proctor and colleagues' 8 implementation outcomes and the number of measures we found across each of them, as well as the range in score when it came to their psychometric evidence strength. In addition to providing tables with this information, we really like these head-to-head graphs depicting the scores on that evidence rating scale. And the colors represent different psychometric properties. And so it allows you, if you're looking for a measure of fidelity in this case, to see, does one measure have evidence of predictive validity? Does it have other studies shown that it is able to predict clinical outcomes? In which case, perhaps it holds promise for your sample, your setting, and could be something that you could bring into your study or evaluation. Now, our team is not the only team to take on reviews of implementation construct measures. In fact, there's 19 systematic reviews of measures across determinants and outcomes as of, earlier this year, which is really exciting because it makes it easier for the field to build evidence for measures and select measures for your own work. If you'd like an overview of the state of the implementation science measurement, look to the 3rd edition of this book. It'll be out this fall, perhaps even when you watch this recording. And it's chapter 14, I believe, that is the measurement chapter, where in this latest edition, we bring a focus on not just implementation outcomes, but dissemination outcomes and a health equity lens to help you navigate that as well. And as I wrap up, I wanted to end with what looks like a complex table. This table is featured in the chapter of that book that I just showed you. And what we try to do here is help you think carefully about dissemination and implementation outcomes that might be a priority for your stakeholders and an interest to you. And think about, what is the right level of analysis for that particular outcome? Is it at the patient level? Is it at the provider level? Is it at a clinic or system level? And what is the theoretical basis for that outcome? Where do I see it anchored in theory and carefully articulated and operationalized such that it could really drive measurement? What are the other terms in the literature for that outcome? This is actually a common problem in new fields where there's proliferation of terms and you see different terms being used to reference the same thing. And it makes measurement identification challenging if you don't have your arms wrapped around the different terms. We also help you think about the salience of the D&I phase for which that outcome is most relevant. You can't measure everything every week or month or day while you're in the field. And so respecting our practice community and stakeholder partners demands that we're clear on when we should expect that outcome to be realized and measure it then and perhaps at an earlier time to test for signal. And we offer phased language according to EPIS, which stands for exploration, preparation, implementation, and sustainment. We also help you think about, is this a latent or manifest variable? Is this really a perception, or is this an artifact, something that we can see objectively, to then help you think about example methods of measurement. And so this is, again, where pragmatic measures really come into play, where self-report, even when we see brief measures being developed, it really can be a burden to try to get to the sample size you need on certain constructs to be able to have confidence that what you're seeing in the self-reports is reflecting reality. And so thinking about other more pragmatic methods of measurement like administrative data, metadata from emails or meetings might really help reduce that burden on our stakeholders, but still allow you to have a rigorous evaluation. So I'll reveal the rest of this table, but not spend enough time for you to digest it, and just remind you that you can find that in the chapter of the second edition of the textbook that's currently available, but also an updated version of this table in the third edition of the textbook that'll come out soon. And it follows onto 2 slides. And now I'll wrap with a summary. So we've covered a fair amount today. I started by talking about high functioning learning health systems, and they may have unique capabilities, from research methodologists to provide the structure for implementation research, or to use the best from implementation research. And ideally, that's bidirectional to maximize the impact of both the learning health system and the field of implementation science. There are indeed numerous frameworks to inform implementation outcomes. And the good news is that there's a lot of synergy there, but that across or within each, you ought to be thinking about health equity and how to unpack those outcomes so that you are able to achieve health equity or surface disparities. I introduced you to causal pathway diagrams. This is its own method, if you will, that our team has been developing and testing and refining through 2 center grant awards and an R01. And we seek your feedback on how useful these are, but we think of them as useful in lots of ways, one of which is to inform pragmatic measurement by surfacing these more proximal outcomes, these signals of early impact. And I showed you that there are numerous systematic reviews that can inform the selection of self-report measures, in particular, of implementation outcomes and other constructs. And finally, we need more pragmatic measures and we should consider these first, especially since most of our implementation outcomes are not perceptions. We're not looking for a perception of fidelity. We're not looking for a perception of cost. We're not looking for a perception of sustainment. I think we're looking for objective realities that those things have manifested because of the hard work that you all have done. And so I hope to see creative, pragmatic ways in which you all are are surfacing those outcomes that you care most about. And on that note, I will acknowledge the several awards that we have that have funded the efforts I featured here, and thank you for your time.